I'm delighted next to welcome Jill Clark, presenting on the Massachusetts Department of Public Health Equity and Justice Programming. Ms. Clark is currently the Director of the Division of Child and Adolescent Health and Reproductive Health at the Massachusetts Department of Public Health. She provides leadership and strategic direction for school, community, and clinical programs intended to provide better access to sexual and reproductive health clinical services, education, and primary care for young adults, including PICC. She received her MPH in Global Reproductive Health from Emory University.
Thank you so much, Liz, and thanks to PICCK for having me here today. I'm so excited to be here, and thank you so much for Loretta Ross for that really thoughtful presentation. I'm hoping to operationalize a little bit some of the concepts that Loretta Ross talked about and give a little bit of insight into how we at the Department of Public Health have integrated health equity and racial justice into our programming at the Department of Public Health. So I'm going to start with what we affectionately refer to as the DPH House. The DPH House is built on the vision and mission of the Department of Public Health. And I want to particularly call out the part of the mission that says that we work to promote wellness and health equity for all people. And we take that very seriously, and we know that we cannot promote wellness and health equity for all people unless we are addressing racial injustices. So this work relies on the pillars of data, determinants, and disparities, as you can see in the house. And I also want to recognize that while the alliteration of the D words is very compelling, we also recognize that we typically talk about inequities rather than disparities. Disparities being differences and inequities being differences that are unfair or unjust. And that's where we'll focus today. So to start with data, what does the data tell us and how do we use this information to drive our work? What we're looking at here is the birth rate per 1,000 Massachusetts women aged 15 to 19, or in other words, the teen birth rate in Massachusetts and in selected communities in Massachusetts. And we know that Massachusetts has the lowest teen birth rate in the country. But when we disaggregate that information by race, we also see that Massachusetts has some of the highest inequities in the country. And so it's really important for us to do that disaggregation and to look carefully at the data that we have available to us to understand where we have been successful and where we still have work to do. Another piece of data that's really important to us, and I think Loretta Ross spoke to this very compellingly as well, is our history. And before I get too far into this slide, I just want to recognize that there is some historical language on this slide that would not be language that we would use today, but it is consistent with the language that's commonly used in the time period that's represented. So this history, hundreds of years of history, is a key element of our two-day racial justice training that many of the staff at the Department of Public Health have had the opportunity to attend. And it starts with the time period known as chattel slavery, beginning in 1619, when the first enslaved Africans arrived on what would become the shores of the United States, and went all the way to the Emancipation Proclamation in 1865. This time period was characterized by drastically disparate treatment in the health system, which of course resulted in very different health outcomes for white people and people of color. Following the Emancipation Proclamation, we entered into a time period of legal segregation, which many of us know as Jim Crow. And the way that this time period is characterized is by an uptick in what we would now call junk science. But these were studies that were published to help support the racial hierarchy that was already present and continuing to take hold. And finally, after the passage of the Civil Rights Movement in 1965, we entered a period that we can call structural racism. And in this time period today, we still see the effects of the prior two periods. One example, but only one, is a 1999 study in the New England Journal of Medicine that showed examples of clear physician bias that were present across a variety of different health systems. And what I really want to point out here is that these first two periods of our history represent 87% of our collective history, both before and after becoming the United States of America. And I think we can all agree that 87% is a supermajority by any count. And so when you hear people saying this was so long ago, all of this is over, or even if you find yourself thinking those things yourself, I ask you to pause and reconsider. 87% is an enormous portion of our history, and the legacy of this time period persists right up until this day. So let's move on to determinants. We often see inaccurately that race is a social determinant of health. Race is not a social determinant of health. There are many social determinants of health that are listed here on this slide, including education, job opportunities, environmental exposures, access to health services, access to housing. But racism impacts the social determinants of health, and thus through that pathway impacts health outcomes. And we know, as Loretta articulately spoke with us about, that it's not just racism. It's also classism, sexism, heterosexism, ableism, and other oppressions that people face, because each of us has both privileged and subjugated identities that impact how we experience these social determinants of health and how we experience health itself. So what this leads us to do then is to understand how important it is to lead with race and racism explicitly, but never exclusively, to always understand these other pieces of oppression that affect individuals. And I'll talk more about that in a minute. And then finally, thinking about disparities or inequities. This slide, I know there's a lot on this slide, but this slide helps us think about, for me, this slide really helps me think about how to understand what we call structural racism, right? So each of the systems listed on this slide is an institution where racial inequity persists in each one of these institutions across this country without exception. And we've come up with different names to talk about the racial inequity that persists in each of these systems, in a different name for each system. In the child welfare system, we call it disproportionality. In health, we're very used to the language of health disparity. In education, we call it the achievement gap. But it's the same thing, the same racial inequity that we see persisting in every system across the country without exception. That's institutional racism, right? Structural racism is where we see the interaction between these systems and how these problems compound to create disproportionate impacts on individuals. And in this case, we're focused mostly on their health. So, for example, many studies show that children that are being disciplined in school are more likely to be referred to the juvenile justice system. They're also more likely to drop out of school. Dropping out, we know, can lead to low-wage jobs, which is directly connected to limited access to healthcare, limited access to health insurance, and health disparities. And so when we have disproportionality in school discipline, that impacts juvenile justice, employment, and ultimately people's health and people's lives. That's structural racism. So what do we do? How do we react once we have all of this information? Well, the way that we've done it in the Office of Sexual Health and Youth Development, which is one of the programs that I oversee at the Department of Public Health, is to be explicit about what our values are, to start from that place. And as I said before, we center racial justice in our program values. We lead explicitly, but never exclusively with race. So there are many other values that we hold dear that we have listed on this graphic, but we focus on and lead with racial justice. Sorry about that. We also create a multi-pronged racial equity movement. And this is a graphic that shows some elements of the Department of Public Health racial equity movement within and outside the department. And what's important about this is that all of these pieces work together. So it's important for us to have a strategic vision of what we are trying to accomplish and where we're going. We use that strategic vision to try to impact the culture of the Department of Public Health and to make changes in the concrete policies and practices that we use both inside and outside the Department of Public Health, and continue to build the capacity of people and systems and organizations, again, within and outside the Department of Public Health, to implement that strategic vision and move us towards racial equity. A more concrete example, again, another busy slide, a more concrete example of how we do this work is to reframe our programs with a racial justice lens. So this is an example of a very simple racial justice reframing tool, and one that we've used for our teen pregnancy prevention program. And basically what you do is walk through the framing element, the 5 questions on the left-hand side, and do that framing from a traditional approach, and then reapproach it again from a racial justice approach. And we find when we frame the problem differently, we also come up with different solutions. So the traditional approach to teen pregnancy is to say that the problem is that teenage Black and Latina girls are getting pregnant at an early age and draining public resources such as welfare. And when we approach it in this way, we come up with solutions that are focused on individuals and highlight values such as personal responsibility. But when we have more of a racial justice approach, we might frame the problem in a very different way. We end up framing the problem to say that youth of color receive inequitable access to sexual and reproductive health education and opportunities for successful transition into adulthood, which results in limited access to health, employment, and access to other social determinants of health. And when we frame the problem that way, we come up with much more collective solutions that highlight the values of equity, justice,
Do you want the peppers, honey?
fairness,
Yeah.
and
Okra?
social responsibility. And so, as a very concrete example of what happened when we framed it differently in terms of this racial justice approach, we changed the name of our program. We no longer call it the Teen Pregnancy Prevention Program, because I'm not in the business of telling people what to do with their bodies. We call the program the Adolescent Sexuality Education Program, because what we are in the business of doing is providing high quality sexual and reproductive health care, making sure that young people have access to supportive adults that can help them identify their goals in life and achieve those goals. That's what we're in the business of doing, and we renamed the program to reflect that. Here's another example of what a reframe might look like. This is the approach for the program that funds PICC's work. So, and the values and principles that we have infused throughout this entire work are the bars that appear at the top of the graphic. And so as we do our work at a variety of different levels, institutional, individual, interpersonal, and societal levels, we're thinking about these principles all throughout. Principles of reproductive justice, shared decision-making, using data to select geographic areas and institutions that are targeted for our intervention, and ensuring that we're appropriate when we target specific populations. So, in summary, what are some ways to incorporate health equity and racial justice that I'd like you to take away from today's presentation? First of all, educate yourself. Know the history and understand how that history impacts the data that you see in front of you. Be explicit. Name racism. Define terms. State your values out loud. Get your people together. And I mean that in two ways. First of all, this is a team effort and nobody can do this by themselves. It's important to make sure that you're working together on this work, but also to think about the specific roles that white people and people of color have in this work, and specifically for white people to help move other white people along to be more engaged in health equity and racial justice in programming. Reframe your program. There's lots of simple tools out there, just like some of the ones that I just shared. And it leads us to understand that when we reconsider the problem with all of the things that we've just talked about, it helps lead us to different and more equitable solutions. And finally, share what you've learned, iterate on the work that you've done, and evaluate your work to make sure it's having the impact that you hope to have. Thanks so much for having me today, and I look forward to the rest of the presentations.
Thank you so much, Jill, for that overview of MDPH's framework and the work that they're supporting. If we have questions, I would be happy to read them out loud as people are typing them into the chat. As people are typing, I'll ask a question. Do you see this new kind of framework and approach at all shifting the programming priorities of the department moving forward, or just how they work within the current priorities?
I think it's a little bit of both, right? And as we do as we do reframing, like I talked about, this is something that is happening across a number of different programs and across the department itself, right? Thinking about what the department's work is and where we can best move the needle on some of the health issues that we're trying to focus on. We have the obligation to really rethink things. For example, we're working with our group that works primarily on maternal mortality on exactly this type of reframing to help them think about how they can approach their work in a more racially equitable way. So this type of reframing is spreading to a number of different programs across the Department of Public Health and helping us rethink our priorities and what outcomes we want to be able to see.
Great. We have a question about, as you made the shift and did the reframing, what was kind of the biggest challenge or most surprising thing you experienced that others could learn from?
There's lots of challenges that we've encountered, and I think Some of it comes back to, it's my get your people. The Department of Public Health has almost 3,000 employees spread across many different organizations. And necessarily there's a lot of different people that are in different places of the racial equity journey. And so making sure that everyone has that clear understanding that I went over incredibly quickly about our history and how that impacts where we are today. And bringing folks up to a foundational understanding of something that none of us were taught about in school. And we've all been explicitly or implicitly discouraged from talking about, right? Conversations about race are difficult to have, particularly for white people. And so we encounter resistance, we encounter white fragility, we encounter people who are struggling on that journey and doing the collective education and work to make sure that people have the opportunity to learn things that have been explicitly denied them, right? That we have worked not to teach in formal education in this country is a really big challenge.
Thank you so much. There have been a few more comments and questions come in, which I think we will have you complete a question document so that we can try to stay on schedule and move on to the next presentation. So thank you so much again for this really kind of concrete update from MDPH.